So as far as the currently available test for detection of HPV, there are three broad types of test. The first one is PCR based. So obviously this is done in a molecular lab and often is cost prohibitive as well as labor intensive in terms of validation as well as uh, uh, actually training the techs. So it's not commonly done in a routine histology lab. It's very sensitive because obviously you are detecting a very low copy of the virus. However, it can sometimes lack specificity, especially depending on the probes you're using, if they cross-react with the low-risk subtypes. Then the second set of tests uses in situ hybridization. And these typically use the HPV specific probes. So in this case, HPV high risk probes. The advantage of this is it's possible to set this up in a histology lab, and like Sharon said, relatively easy to train the techs and bring them up to speed on the technique. However, the disadvantage with this is it has low sensitivity in terms of picking up virus, and the uh, main disadvantage is it will not detect the biologically active virus. So unlike the RNA-based test, which detect biologically active infection. So in terms of the sensitivity and the clinical utility, these tests are not very good. P16 is almost widely used in majority of the labs as a surrogate marker for HPV infection, and in fact, in endometrial or endocervical biopsies, especially endocervical, the P16 is most commonly deployed to screen for HPV infection. P16 is a good marker. It's cost effective and it's rapid. But one of the biggest disadvantages with P16 is it lacks specificity. We've seen cases which are P16 positive but turn out negative for HPV RNA-ish. And it's believed that the false positivity for P16 is largely due to presence of either a cross-reactive virus, which is not related to HPV, or due to false positivity related to the internal protein, which can be overexpressed due to reasons other than HPV infection. So that's why the P16 positivity does not always suggest HPV related process. Next slide, please. So some of the newer tests that have come up in the last few years is the RNA or the mRNA-ish, and also RNA-based PCR. So both these tests basically target the E6 and E7 genes within the HPV virus. Both are equally sensitive. In fact, when we initially started with HPV testing, we used to do a mRNA PCR in our lab for cervical carcinomas, and we actually validated that for even head and neck carcinomas. So that it has a very good sensitivity as well as specificity compared to DNA-based test. However, the biggest challenge with the PCR-based testing is, first of all, the separate space, and the biggest disadvantage was the reimbursement. Unfortunately, these tests are not readily reimbursed by most of the payers. And so, as a clinical reference lab, we really struggle with bringing up this test or keeping it live for too long. And then we decided to switch to RNA-based ish, which, when we validated along with PCR, had similar sensitivity, but yet it could be done in histology and had good reimbursement. So the biggest advantage with the RNA-based approach, as I said earlier, it's directly showing you biologically active disease. Meaning, if you have a RNA-ish positive, that means the HPV virus is actively replicating, or the episome is part of the host DNA, and so it's active infection.